Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are going to discuss another 3 Vivas in fellowship exams. But before that, Maddie, you just returned from your holidays. How was your vacation?
It was very good. We went to New Zealand and went skiing and it was great. But unfortunately, we both got COVID. So I'm isolating at the moment.
Fair enough. That was inevitable, I guess.
Yeah.
But anyway, that was your birthday, I guess. And
yeah, it was.
Wish you a very belated happy birthday.
Thank you.
So let's dive into today's first case. So you receive a phone call from a registrar and she tells you that 36-year-old female who has been admitted in ICU for last 5 days. Now, this lady was admitted with subarachnoid hemorrhage with a World Federation Neurosurgical grade of 3 from a right MCA aneurysm. She underwent emergency coiling when she was admitted, and now she has been extubated for 24 hours. And she has an EVD in situ to drain at 10 centimeter of water. Her GCS has been 10 to 12 until tonight, when she was noted to be drowsy and not be herself for 1 to 2 hours. She's becoming more difficult to rouse now. So what will be your response?
So I think that there are both logistic and clinical aspects to this case. I'm concerned that this patient has had a deterioration in her neurology, which might be either secondary to a complication of her subarach, such as rebleeding, hydrocephalus, vasospasm, or seizures, or due to a new pathology. And my response would involve communicating these concerns to the registrar and advising them about the important aspects in assessing and stabilising this patient. So firstly, in terms of the logistic issues, I haven't worked with this registrar previously and it's the middle of the night and I'm unsure of their level of seniority. So I'd want to provide extra support either through the unit or most likely by coming in myself to assist, depending on the urgency of the situation. I'd also advise the registrar to notify the neurosurgical team and prepare this patient for a CT scan, most likely. So this would involve a transport monitor, adequate access, and to inform radiology. I'd also advise the registrar to the importance of the initial assessment and stabilisation. So the initial assessment would involve a rapid assessment of the patient's vital signs and neurology. So assessing her saturations, ensuring adequate protection of her airway and assessing the difficulty of the airway. So she's recently been extubated, so getting an idea of the previous grade of intubation, getting her supplemental oxygen and assessing her aspiration risk, and providing simple airway manoeuvres if she's not maintaining her airway. If this registrar didn't have any anaesthetic experience or there was concerns about the difficulty of the airway, then calling for backup support, which would involve the anaesthetic team. Then assessing the hemodynamic status, so including the heart rate and the blood pressure. So hemodynamic support required, aiming at a systolic blood pressure of 120 to 150 at present, as the aneurysm has been secured. So this might involve vasopressor support. And assessing the neurology, so what the exact GCS breakdown is. So are there any focal deficits? What are the pupils doing? What is the current ICP? How much has the EVD been draining and is it blocked? And is there any blood in the EVD or any clinical signs of seizures? So depending on this neurological assessment, my advice would vary. So if the EVD is not draining, assessing that it's not clamped, there's no kinks, that it is oscillating and that the ICP has a normal waveform. If this is all present, then to briefly lower the drain and observe to see if any CSF is draining. If there's any signs of seizures, to start low-dose IV benzo and load with Keppras with 20 milligrams per kilo. And if there's delayed cerebral ischemia, considering hypertensing this patient, but this would generally be a diagnosis of exclusion, so it wouldn't be involved in my initial management. And then I'd also be looking for or getting the registrar to assess for other contributors or causes of a decreased level of consciousness. So reviewing the medication chart, looking for any metabolic changes, so getting an ABG, a BSL, electrolytes, and to see if there's been any recent changes, and assessing the temperature trend and for any signs of sepsis.
Yeah, that's great. And I guess the CT brain report now shows that there is no new acute intracranial pathology, and it's thought to have delayed cerebral ischemia or DCI. So can you tell us more about what is DCI and what are the risk factors for this condition?
So delayed cerebral ischemia is the development of a new focal neurological deficit or a decrease of at least 2 points on the Glasgow Coma scale, which lasts more than 1 hour and wasn't apparent immediately after aneurysm occlusion. And this cannot be attributed to other causes. So DCI is traditionally thought to be secondary to vasospasm. However, now more recent studies postulate that radiological vasospasm may be associative rather than causative, and that the etiology of DCI might be multifactorial. So risk factors for DCI include factors related to the initial subarachnoid and patient factors. So subarachnoid factors include a higher radiological grade or a higher clinical grade. Radiological grade is the most important risk factor for delayed cerebral ischemia. And patient factors include smoking, being female, diabetes, a younger age, having hypertension or hyperglycemia, or previous cocaine use.
And can you briefly list the management options for delayed cerebral ischemia?
So the management aims to prevent or minimize any further neurological injury. So the mainstays of management are pharmacological therapy, hemodynamic optimization, and then there are endovascular therapy options. Pharmacological therapy is nimodipine, which is mainly preventative, but has been shown to reduce the risk of DCI. Hemodynamic optimizations involve vasopressors titrating to a higher blood pressure. So the thresholds vary. In my practice, we do a systolic of 140 to 160 with regular monitoring of patients' neurology and then adjusting the blood pressure targets depending on their neurological response. And aiming euvolemia. Traditionally, there was a tendency towards aiming for hypervolemia, but this is not evidence-based, and currently it's mainly euvolemia that we aim for. Endovascular therapy options include balloon angioplasty or intra-arterial pharmacological therapy such as milrinone or verapamil.
That's right. I guess that's why probably it's important to discuss with neurointerventional center about the management of this condition. And often these patients are managed in specialized centers in most of the cities. Now, let's dive into second Viva for this podcast. So 27-year-old male who is roughly around 80 kilogram found after an explosion in his garage. When he arrived in ED, the GCS was around 8, E2, V2, M4 with a SATs of 88% on 15-liter oxygen with a respiratory rate of around 40, heart rate of 123 beats per minute, and the blood pressure of 88 on 45 millimeters of mercury. On clinical examination, he has suffered from significant burns to his face, chest, and limbs. So what will be your approach towards the assessment and the management specific to the burn injury of this patient?
So assessment and management involves trauma team activation, targeted history, primary and secondary surveys per the ATLS guidelines. But specifically from a burns perspective, specific attention needs to be paid to early securing of his airway, management of his hypoxic respiratory failure, adequate fluid resuscitation and hemodynamic support, adequate analgesia, and evaluation of the extent and appropriate management of his burns. From a logistics perspective, it's important to have trauma team and burns team activated and available, and full monitoring on the patient, but this may be limited by the extent of his burns, especially ECG monitoring. And he'll eventually need admission to ICU, which might be via theatre depending on the findings of assessment. If this is not a burns centre currently, he'll need retrieval organised to the nearest burns centre. A target history needs to be performed. So patient-related would involve his allergies, medications, comorbidities, and when he last ate or drank. History around the trauma, including events surrounding the explosion in the garage, his observations on the scene, the timing of the injury, so the timing of the initial burns, and any evidence of any drug or alcohol ingestion, and any treatment prior to arrival, which include any first aids to the burns, such as whether they were placed under water, analgesia, and any fluid already given on scene or en route to hospital. In terms of ongoing assessment and management, this would involve primary surveys. So in terms of the airway and C-spine control, it involved urgent securing of the airway given his hypoxic respiratory failure and facial burns, and looking for particular warning signs of airway involvement, including singed nasal hairs, hoarse voice, or stridor. It might be a difficult intubation, so would require anaesthetic and potentially ENT input or on standby. and adequate planning, including ideally a video laryngoscope, inline stabilization, an RSI, and adequate pre-oxygenation, and an insertion of an NG tube. C-spine precautions may be difficult to maintain, especially if there's facial or neck burns. So ideally, once intubated, he would need sandbags. In terms of the hypoxic respiratory failure, it involved assessing and treating contributors to this hypoxic respiratory failure. So restrictive burns around the chest might require espirotomies. You'd need an exam and chest x-ray for sequelae from the trauma, such as pneumothoraces, which might need chest drains, an ABG for carbon monoxide or methemoglobin levels, and lactate, as well as adequacy of ventilation and consideration of cyanide toxicity, all of which might contribute to his hypoxic respiratory failure. And then generalized lung protecting ventilation, aiming a plateau pressure of less than 30 and titrating SATs to 92% or more, unless there's evidence of carbon monoxide poisoning or methemoglobinemia. From a circulation and hemodynamic support, IV access is crucial, and this is generally through intact skin, but can be through burnt skin if required. And he'll need full blood set, including a group and hold, as he might need transfusion, full blood count to assess for hemoconcentration, electrolytes and LFTs for organ functions, and an AKI, a CK level for evidence of rhabdo, BSL due to his low GCS, and then considering other more specific blood tests such as troponin if evidence of sternal fracture or blast injury or cardiogenic shock, and alcohol level or paracetamol level if concerns about co-ingestions. And we need to assess the extent of the burns, looking also for any specialised burns areas such as ocular or airway involvement. Fluid resuscitation is crucial in this patient, and I use the modified Parkins formula, so 3 mils per kilo per total body surface area, with the first 50% in the first 8 hours and then the remaining in the next 16 hours, and using crystalloid to begin with, but avoiding large volumes of normal saline and ensuring fluids are on a warmer. He'll also need an IDC to monitor his fluid balance, aiming for 0.5 mils per kilo per hour of urine output, and assessing and treating for any contributors to his hypotension, which may be from sequelae of his trauma, such as a blast injury or bleeding, or secondary to his burn, such as large fluid shifts or cyanide toxicity. And then more particular, again, to the burns management would be wound management involving cling film dressings and burns team involvement regarding debridement, and assessing for any complications of the burns, so escharotomies if there's circumferential burns, and close neurovascular observations, assessing for rhabdomyolysis and considering antimicrobials if the wounds are significantly contaminated. He'll also need a tetanus shot, and he needs specific care being placed on thermoregulation, and as he's got a high risk of losing heat, so ensuring it's a warmed room, warm fluid or blood products, minimising exposure and using a bear hug if required, and ensuring adequate analgesia, so bolus of opiate initially, regular paracetamol if there's no co-ingestants, and then infusion of opiate once intubated. And he'll need ongoing NG feeds eventually, as he will be hypercatabolic from the burns. Other aspects in this case will be assessing for other injuries and for focal neurological deficits. He'll likely need a PAN scan due to the mechanism of his injury, and then a secondary survey once he's stabilised.
Yeah, I guess that's another important point, that often these burns patients can suffer some other injuries, and I think not missing that PAN scan is the important thing. So I guess the airway management, obviously the fluid management and burn-specific management are the kind of key domains in any burns patients. Now, can you please list the methods available to estimate the extent of his burns?
So there are several methods available. The Lund and Browder chart is the most accurate method, as it compensates for variation in body shape with age. So there's age-specific charts. The Palmer surface method is another method which uses the surface area of the patient's palm, including the fingers, which is equal to 1% total body surface area. And it's more accurate for smaller burns, or sometimes for larger burns where you can subtract just the area of unburnt skin to get the total body surface area. And the final method is the Wallace rule of 9. So the body is divided into areas of 9%, so 9% for each arm and 18% for each leg. And this method is faster and more convenient, but it's not accurate in children or in obese patients.
Yeah, that's correct. So I guess one of the most controversial area in burns management is the fluid management. And often this question asked candidates that what's the evidence of colloid versus crystalloid in management of burns. Now you work in burn center. So can you summarize the evidence and also tell us what's your practice?
So colloids are sometimes recommended as part of fluid resuscitation in burns patients, as they're thought to act as a plasma expander and be a fluid-sparing agent, and then potentially counteract hypoalbuminemia, which is often present in critically ill burns patients. But there's a paucity of high-quality evidence about the utility of albumin. A meta-analysis summarised most of the data in 2014, which looked at both randomised and non-randomised clinical trials, and found that albumin was associated with a lower incidence of compartment syndrome and mortality. But the authors acknowledged that there were significant weaknesses within the available evidence, and there's a lack of randomised studies and many retrospective trials included. There's been many smaller trials, which some have hinted at a benefit in burns patients in terms of mortality, but there's still no firm consensus. In clinical practice, however, like in our centre, we use albumin for what we term difficult burns resuscitation. So these are in patients who, despite large volumes of crystalloid, are still not maintaining an adequate urine output. And then we add 4% albumin into the burns resuscitation as part of the algorithm. Like I said, there's no clear high quality evidence that this actually has a benefit in terms of patient-centered outcomes.
That's correct. And also doing a trial in burns patient is quite challenging. So I guess that's probably the reason why we don't have any high quality evidence available, or probably we are not likely to get one.
Yeah.
So let's move on to the third and final Viva for today's podcast. So 45-year-old male admitted with upper GI bleed and has undergone endoscopy where they found esophageal varices and they performed banding. His GCS at presentation was 15. However, over the next 24 hours, he has a progressive decrease in his conscious state. Now, you're called by the new medical consultant who suspects that this patient has hepatic encephalopathy and wants him to be admitted to ICU. How would you assess this patient to determine the cause of his altered consciousness?
So there are many potential causes for this gentleman's deterioration in conscious state, and this could be complications of his initial procedure, such as GI bleeding or delirium, complications secondary to his hepatic dysfunction, such as coagulopathy with an ICH, or the new pathologies such as septic encephalopathy. And many of these pathologies can also result in hepatic encephalopathy. So assessment would involve a targeted history, examination, and investigations. In terms of history, important aspects would be comorbidities. So in terms of, we're presuming he has hepatic dysfunction, we would like to know the information about the extent, so the child Pew class or MELD score, and whether he's had any synthetic dysfunction, underlying cause of his liver disease, and any previous complications such as previous hepatic encephalopathy, which would make it more likely for him to have again. Other comorbidities such as renal failure, thyroid, adrenal, pituitary disease, or autoimmune conditions, which can result in decreased level of consciousness. Medications or toxins. So I'd like to know about the normal medications he had at home. So whether he's had the risk of withdrawing or missing appropriate medications, whether any new medications have been given. Could this be an adverse reaction or interaction or accumulation secondary to organ dysfunction? And whether he has any alcohol or drug use socially. I'd like to know his allergies and also his trajectory in hospital. So his duration of admission, any localizing symptoms for infection, his vital signs, any recent falls, his bowel habits, which may hepatic encephalopathy more likely, any recent blood tests and organ function, and the endoscopic report to evaluate what was actually done. In terms of examination, important aspects will be vital signs, including whether he had a fever, his saturations, and neurology, which would involve a level of consciousness with the GCS breakdown, any signs of raised ICP, such as papilledema, and any focal neurological deficits, and then specific neurological signs, which would make me more suspicious of hepatic encephalopathy, such as asterixis, dysarthria, nystagmus, hyperreflexia, or clonus. And then any signs of chronic liver disease, such as jaundice, ascites, Palmer erythema, or spider nevi, or signs of other pathology that might cause a decreased level of consciousness. So any signs of infection, trauma, endocrinopathies, or autoimmune conditions. Investigations will be bedside bloods, imaging, and some other tests. So bedside tests like an ECG, looking at any arrhythmias, a UA for infection, a chest X-ray to look for infection or aspiration, an ABG or VBG for gas exchange, his lactate and glucose. Blood tests would involve a full blood count to look for his HB for signs of an upper GI bleed, platelet-free synthetic function, and white cell count and differential for infection. A UEC for signs of an acute kidney injury or a raised urea out of proportion of creatinine, which may suggest further upper GI bleeding. LFTs for his hepatic function, coags, whether for any potential coagulopathy secondary to his hepatic dysfunction. Ammonia, mainly as a trend, just for the trajectory, and blood cultures if concerns regarding sepsis, and imaging, chest X-ray, as I said, and potentially a CT brain to look for signs of intracranial hemorrhage or any focal abnormalities. Other potential investigations would involve potentially an LP if signs of meningism, an EEG if any concerns about seizures, and acidic tap if concerns re spontaneous bacterial peritonitis.
Great. So what are the potential precipitants of hepatic encephalopathy?
Hepatic encephalopathy is a spectrum of potentially reversible neuropsychiatric abnormalities, which can occur in patients with liver disease and or portosystemic shunting. Potential precipitants include infection of any source, so including things like FBP or UTIs, drugs, commonly narcotics, alcohol, benzodiazepines, or non-compliance or accidental missing of medications such as lactulose. Metabolic causes, including metabolic alkalosis, electrolyte disturbances such as hypokalemia, renal failure, hypoglycemia, hypoxia, or any excessive intake of protein. And vascular causes such as GI bleeding, hepatic or portal vein thrombus, hypovolemia of any cause, such as secondary to vomiting or diuretics, or large volume paracentesis, portosystemic shunting such as post-TIPS procedure, or any other causes including constipation or hepatocellular carcinoma.
Now, often in these patients with hepatic encephalopathy, we ask our registrar to send the ammonia levels. So what is the role of ammonia measurement in the diagnosis of hepatic encephalopathy?
So the diagnosis of hepatic encephalopathy is clinical and involves a focused history exam and investigations to detect the characteristic neurological changes of hepatic encephalopathy, identify potential precipitants as listed above, and to exclude any other potential cause of deterioration. The role of ammonia measurement in the diagnosis remains controversial. So although ammonia is the best known neurotoxin that precipitates hepatic encephalopathy, is not specific for hepatic encephalopathy, is not required for the diagnosis, and its level does not correlate with clinical severity. Furthermore, its measurement can be confounded by sample error because it requires a sample to be placed on ice and can be elevated in various non-hepatic conditions, such as certain inborn errors of metabolism with drugs such as valproate and malignancies such as myeloma. Ammonia measurement, however, is relatively simple, non-invasive, and may help add support to a diagnosis of hepatic encephalopathy. But patients can have hepatic encephalopathy with normal ammonia levels and conversely can have elevated ammonia levels with no clinical signs or symptoms of encephalopathy. A retrospective review of 1,200 patients with cirrhosis and a diagnosis of hepatic encephalopathy found that there was no correlation between lactulose dose and ammonia level, and that ammonia measurement did not affect any patient-centered outcome. So in summary, ammonia measurement has very little role in the diagnosis of hepatic encephalopathy, but its measurement most likely just confirms our existing clinical findings and diagnosis or our clinical bias. Interestingly, there was like an NEGM journal watch thing that said basically it's time to stop measuring it.
Yeah, that's true. It's one of those things in ICU that we keep doing despite having no evidence. And everybody likes to look at some level which says 150 and 200, and everybody gets excited that patient has got elevated ammonia.
Yeah.
So there are a lot of fallacies attached to this investigation. So you're right. It's ultimately a clinical diagnosis. Now, after the review of this patient, you agree that this patient has hepatic encephalopathy. What are the factors that would make you admit this patient to ICU for ongoing management?
So I think these factors are patient-related or logistic-related. So patient-related would be need for ICU-level support. So this would be things like hemodynamic compromise requiring vasopressors, requirement for intubation, such as due to worsening GCS or aspiration causing hypoxic respiratory failure, or worsening end organ functions, for example, hepatorenal syndrome requiring CRRT. A need for closer observations, such as the deteriorating trajectory requiring more frequent observations, or a presence of an advanced care directive or other comorbidities that would make ICU admission unsuitable, which is less likely in a 45-year-old but still might be present. Then logistic aspects would be staffing related. So need for regular treatment such as hourly lactulose, which might not be able to be facilitated on the ward, or hospital related. So ability of the ward or a higher level unit to provide closer observations or more intensive treatment without ICU admission.
Yeah, that's right. Because often these patients can be managed in the ward and only for certain selected criteria you need to admit them to ICU. So can you please outline the specific management of hepatic encephalopathy?
So specific management would involve identification and treatment of precipitating factors, ammonia lowering therapy, and supportive therapy, including nutritional support. So identifying and treating precipitating factors would be aiming euvolemia and avoiding dehydration, treating the GI bleed. So he's already had an endoscopy, ensuring that there's no further GI bleeding, transfuse appropriately and a PPI, correcting electrolytes and metabolic disturbances, especially hypokalemia and hypoglycemia, treating any co-infections with antimicrobials and source control, and rationalising medications to seize hepatotoxins or potential contributing agents. Ammonia lowering therapy would involve lactulose, titrating to his bowel habit, so aiming 2 to 3 soft stools per day. We can give this orally if he's able to swallow or through an NGT if it can be safely inserted, if he doesn't have significant varices. Otherwise, can give PR. And rifaximin 550 milligrams BD. This is only available orally. And then other important supportive management for the hepatic encephalopathy would be nutritional support, so thiamine and multivitamin, a high fiber diet, dietitian review, and may need NG feeds depending on his level of consciousness, and close monitoring and support of his organ function. So may need intubation if severe encephalopathy, monitoring his urine output and renal function as risk of acute kidney injury. And he may need things like NORAD or terlipressin and congalbumin if hepatorenal syndrome is suspected.
Thanks, Maddie. So I guess that's the end of our 3 Vivas for today. Now, obviously you got COVID, so probably you don't have much time to prepare any joke.
No, that was the first thing I prepared. It wasn't. No, it wasn't.
Okay. Fire.
Okay. Why are burn surgeons so socially progressive?
Because they don't burn bridges?
No, because their job is addressing change. That one's from Jules.
Oh, that was a really clever joke, I must say. I wouldn't have thought about that one. So well done, Jules. Thanks, Maddie. So that's the end of our today's episode. We'll be back in month's time with another episode with 3 Vivas. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.